So it's a difficult job I have now, right? But I have already said my opinion, and I do believe we are ready for prime time. And my job is to say here, what do we need to do in other settings so that we can get more data? So these are my disclosures. And just to remind all of us, despite the major advances in treatment and prevention, the HIV pandemic continues to pose a major global health challenge. And by the end of 2021, about 38 million people were living with HIV worldwide, with still 1.5 million new infections a year. So, and this is the cascade of care. In 2021, 85% of people living with HIV knew their HIV status, and 75% of them were assessing treatment, and 68% were virally suppressed. These seemingly small gaps add up to leave only 1/4, 25% of people living with HIV globally not on treatment, and roughly 1/3 with unsuppressed viral loads. So although there are highly effective options, as we saw, for once-daily oral antiretroviral therapy to treat HIV, not all patients living with HIV on ART are virologically suppressed. Adherence barriers to oral regimens are common and span individual and structural factors, including stigma, forgetting, unstable housing, food insecurity, insurance lapses, or prohibited copays, mental illness, substance use, transportation challenges, and stockouts. Long-acting injectable agents administered monthly or less frequently could circumvent some of these barriers, holding great promise to improve treatment outcomes. So, long-acting agents have been developed, as you already saw, for contraception and other disease states like psychiatric illnesses. And as you also heard, randomized controlled trials have shown that both monthly and every 2 months CAB-LA with rilpivirine is non-inferior to monthly injections in the FLAIR, ATLAS, and ATLAS 2M studies. Also, in the SOLAR study, you saw the comparison between every 2 months injectable or oral bictegravir, and you also saw that it proved to be non-inferior. So, I'm sorry. There are also other agents in resource-rich settings, but as ibalizumab and also lenacapavir that has been approved for use in individuals with failing antiretroviral therapy, but I will focus my presentation on CAB plus rilpivirine. So, patients virologically suppressed for the past 6 months or more are the optimal candidates for switching to long-acting cabotegravir plus rilpivirine. But important contraindications, as you already heard as well, are prior ANSTI or NNRTI resistance, except for K103N, chronic Hep B infection or no Hep B immunity, and not on drugs with significant interactions. And as an example, rifampin, and here we come to a specific, not a specific, but a very important aspect for implementing these drugs in resource-limited settings where tuberculosis is a major co-infection. Anyhow, there are ways so that we can implement it after the individual has finalized the TB treatment, and there was shown in several studies that adherence after the treatment of tuberculosis in co-infected individuals, adherence to ARTs can become worse after the TB treatment is over. So that could be an important moment where an injectable long-acting agent could be very useful. All of these studies started LA-CAB with rilpivirine in virologically suppressed patients. However, given the difficulties with adherence in multiple contexts worldwide, studies using LA-ART in adherence-challenged patients are highly needed. So as Laura already showed, that there was this demonstration study conducted at Ward 86 in San Francisco General Hospital, which serves a publicly insured and uninsured population of people living with HIV in San Francisco. Provides the most extensive experience today with 133 patients receiving long-acting rilpivirine, and 57% of them were virologically suppressed on oral ART, but 43% had viremia on ART due to adherence challenges. And after 26 weeks of treatment, the rate of suppression among initially viremic patients was 96.5%. While these results are not directly comparable to data from randomized studies, these are very important results for us to consider. So long-acting ART can be really a game changer, and innovative study designs to rapidly evaluate this important new strategy among viremic patients are highly indicated. Although infrequent, confirmed virologic failure with drug resistance mutations occurred, as you also heard from Laura, during clinical trials in patients with online injections of long-acting ART, but only in 1 to 1.5% of participants. The presence of rilpivirine resistance mutations at baseline, subtype A6 or A1, and high BMI were all significantly associated with virological failure risk. Although long-acting ART points to be a highly effective alternative for HIV care, historically, the introduction of evidence-based technologies into public health programs in low and middle-income countries have been fraught with delays that result in missed opportunities for impact. So far, only 3 clinical guidelines have incorporated long-acting CAB plus rilpivirine. The EACTS, the US did HHS, and the IAS USA, but I have not mentioned the BIVA guidelines. A few demonstration implementation studies are being conducted in Africa, but I was unable to find information of any studies being conducted in other regions, such as Asia or Latin America. So I will just show you briefly examples of studies that are being conducted in sub-Saharan Africa. The CARE study is a vital stepping stone for bringing injectable ART to treatment programs in sub-Saharan Africa, gathering robust evidence to support its use in Africa, as well as to build experience before large-scale implementation can happen. Enrollment to the study has been finalized, and initial results are expected very soon. Participating sites are in Uganda, Kenya, and South Africa under the coordination of Dr. Sisikitio from the JCRC in Kampala. Another study is the Impala study, that is a pragmatic phase 3 open-label randomized controlled trial on the efficacy, safety, and effectiveness of injectable CAB rilpivirine in improving HIV control in Kenya, South Africa, and Uganda, under the coordination of Dr. Fiona Cresswell, and it will enroll 540 participants. The LATA study is a randomized open-label 2-arm 96-week trial in virologically suppressed adolescents aged 12 to 19 years of age in sub-Saharan Africa as well. And this study will enroll 460 participants. The OLA study is another example of a study that will evaluate the acceptability, appropriateness, and feasibility of a pharmacy-based administration model of CAB rilpivirine over 12 months. And lastly, the affinity study will evaluate the acceptability, tolerability, and feasibility of long-acting injectables, again in adolescents and young adults in Africa. As you already heard, advantages and barriers of long-acting implementation of long-acting ART are anticipated in a range of settings and are related to the drug itself, to the people who are in need to use long-acting ART, and to the healthcare systems. Some of these aspects are unique to low and middle-income countries. For instance, long-acting cabrilpivirine offer important advantages over oral therapy related to stigma and pill aversion, but is not without implementation challenges that must be taken into consideration before initiating the long-acting therapy. Parenteral long-acting regimens increase choice and autonomy for people living with HIV. Long-term adherence has been affected by stigma and fear of HIV status disclosure if pill bottles are seen. Injectables are discreet and may promote adherence in settings where disclosure has not occurred or is unsafe. Long-acting regimens such as cabrilpivirine are nucleoside-sparing two-drug regimens, which reduce tenofovir-associated toxicities, for example, renal and bone. And important barriers are in place for implementation in LMICs, such as I mentioned already, drug-drug interactions with rifampin, limited safety and efficacy data in low and middle-income countries that is being gathered in some places, but not in others, and where we have high prevalence of NNRTI resistance and insufficient data in pregnant women and children. On the individual level perspective, injectable CAB has the great potential to be used at targeting those who struggle most with adherence and may improve well-being and quality of life. Nevertheless, long-acting ART also requires more frequent clinic visits and may impact individuals' access regarding transportation insurance, for example. It also has gluteal injection issues related to obesity, buttock implants of silicone for the transgender population, and tattoos. Finally, so far, there are insufficient data on its use during pregnancy and breastfeeding, as I mentioned it, as well as no PK data on specific populations. Some other factors may complicate the implementation of long-acting, such as the lack of routine baseline resistance testing in low and middle-income countries, infrequent viral load monitoring or less frequent than needed viral load monitoring, the need to exclude Hep B and TB co-infected individuals. Generalizable efficacy and safety data from low and middle income countries is required, including for these individuals with co-infections and pregnant and breastfeeding women. So long-acting ART has the potential to address some of the achievement gaps that persist with daily oral therapy, but expanding the method choice, improving adherence and quality of life. In prior and current trials, study product has been administered in a clinic-based setting. For the introduction of the product, the best site for service delivery will also need to be determined. System capacities with larger number of visits than with oral ART, duration of appointments, location of service delivery, pharmacies, mobile health vans, in-home services. Health services is in difficult-to-access settings, tracking of injections, retention system, and the supply chain and logistics. Long-acting ART brings challenges for the current differentiated service delivery building block that will need to be adapted to accommodate the product and clients' needs. Being aspirational with more advanced long-acting ART regimens, we hope that these challenges can be reduced and an optimized differentiated service delivery model can be developed, allowing for longer intervals to clinic visits, use of non-traditional health models such as community-based organizations, mobile vans, pharmacies, and pharmacies can be incorporated. So, also, gluteal injectable administration is not feasible for everyone, as I mentioned it. So other sites for injections need to be explored. An alternative large muscle, such as thigh muscle, could be a potential site of administration for individuals experiencing injection site fatigue or intolerability, or having contraindication for gluteal muscle administration, such as by having buttock implants. So results from a PK study have been recently presented, and overall, 30% of the participants, only 30% prefer tight injections, citing ease to access to injection site as the top reason. These results support rotational short-term CAB-LA rilpivirine with the lateral tight administration, but there were also a lot of complaints related to pain in the local of the injection. But this can be a strategy, particularly for those experiencing fatigue from the gluteal injections. In summary, long-acting agents are a game-changer option, in my opinion, for treatment and PrEP. Most in-need populations might benefit from these options. Logistical challenges need to be addressed to make it happen, though. But it could widen the access gap if equity is not considered from scratch. A network of peer navigators may be needed to reach and support some of the left-behind populations. Research priorities include populations with different vulnerabilities, children and younger, transgender, people in jail, psychiatric patients, people in nursing homes, and homeless individuals. Nobody should be left behind in this new treatment paradigm. Thank you.